morning, good afternoon, everyone. Thank you for joining our initial CAMRA PUBGEM-Africa webinar, which is the first of a series of webinars and virtual cafes that we'll be running over the next couple of months, leading into the consortium meeting in Mauritius in November. So I just want to kind of kick us off in the discussion today. So we have our moderator today is Dr. Nubwa Medugu. She is a clinical microbiologist at the International Foundation Against Infectious Diseases in Nigeria, based in Abuja, Nigeria, and is one of the investigators on our CAMRA projects, our CAMRA DSI-Africa project. So I would give the floor to Dr. Medugu to go ahead and introduce the topic and the speakers. Thank you.
Thank you so much, Dolo, for the kind words. If you can please enable my video. So I see we have quite a number of participants already in the house. So I want to tell you good morning, good afternoon, good evening, because I can see names that seem as if they're from a wide variety of regions. So really welcome to our first CAMRA PUBGEM Virtual Science and Society Cafe. Today's cafe is the first of a series, and it is focused on ethical and responsible data science for infectious disease surveillance and AMR research in Africa. Now, this is very key given the current trends in infectious diseases across the globe. So as we gather here today, we know all around the news is the fact that Africa is facing significant public health challenges due to Mpox, which is why our moderator for today, the official one, couldn't be here. She's representing her country in an emergency Mpox global meeting. There's also malaria, TB, HIV, Ebola. A lot of infectious diseases have had their toll on Africa. And the use of data science technologies and tools have therefore become crucial when it comes to how to respond to these global emergencies. As these data science tools become more and more available, it also raises a very important ethical question and other ethical considerations for the responsible use of data, including protecting privacy, security, actually obtaining informed consent, and many researchers falling short of that, and also ensuring that marginalized communities benefit equally from the advancements that are available in data science. So today we have experts, and we're really privileged to have these three experts in the room to share with us their vast experience in the field of data science as it regards ethics. So first off, we have Professor Stephen Obaro, and then Dr. Gerald Mbua, and last but not the least, Professor Morenike Folayon. So they are experts in data science, bioethics, and AMR research, with a lot of them also having a good base of digital disease surveillance. So they will all, along with us, engage in discussions on the intersections of these fields that I've called, and together we'll explore ways to foster interdisciplinary dialogue in the scientific, societal, and also ethical considerations for infectious disease surveillance. So this whole cafe is going to last 90 minutes, and we hope that you will all be attentive. Each session is 25 minutes, after which you have 10 minutes to ask your questions or drop your questions in the chat box. But then there's also the panel discussion where you can also lend your voice, your comments, and also ask your questions to our experts. So without further ado, allow me to welcome you to our first session. And the title is The Future of Data Science in Infectious Disease Control and AMR, Opportunities and Challenges in Africa. Our speaker is Professor Stephen Obaro. Professor Stephen Obaro is a household name globally, but especially in sub-Saharan Africa. He is a distinguished expert in infectious diseases, especially in pediatric infectious diseases, but also across the globe, known for his expertise in antimicrobial resistance. He's the principal investigator of the CAMRA project and has led groundbreaking research in the field, leveraging data science and innovative approaches to convert infectious diseases and AMR in Africa. Professor Obaro's work has had a significant impact on public health policy and practice, and he's a well sought after speaker and advisor on several critical issues. This week, he was inaugurated into the National Task Force for Antimicrobial Resistance and Stewardship by the Minister of State for Health for Nigeria, acknowledging his expertise in AMR. His presentation today will explore the future of data science in infectious disease control and AMR in Africa, highlighting opportunities and challenges in the field. So please let's give a round of applause to Professor Obaro as he comes on stage.
Great. Thanks very much, and thanks very much for the kind introduction. So I would want to start off by just saying that I am a pediatric infectious disease physician. I'm not going to pretend to be a data scientist or an ethicist, but I would basically want to share experience and perspective of my work as a clinician, a clinical scientist, and also to a large extent activities that I have engaged in on the continent. So we'll be sort of addressing the ethical and responsible use of data science in infectious disease surveillance, and what I would try to do, next slide please, is to try and provide some background and review in context what we are doing through this NIH-funded project, and critically address some practical issues on data sharing, the risks and benefits, and also the challenges. Next slide, please. So clearly, genetic.
Sorry, Prof. Sorry to interrupt. It's a bit difficult to hear you. I don't know if maybe you can go closer to your microphone. We had a couple of questions in the chat about it as well.
Can you hear me better now?
It's still a bit muffled, but I guess maybe we'll continue. But it's a bit muffled. It sounds like you're far away from the microphone.
I'm as close to it as I possibly can. All right, is it better?
Well, not really. It's still the same. Well, anyway, I guess we can continue in any case.
Right. Okay. My apologies for that. I am not in my usual base, but I've tried to run as best as possibly can within the circumstance. So, genetic sequencing of pathogens in general has taken place in some form since the early 90s. But within the past decade, pathogen sequencing has taken a center stage in public health disease control and epidemiology widely. It's been used effectively in understanding the dynamics of transmission of MERS, SARS, more recently SARS-CoV-2, COVID-19, and currently the mpox outbreak. Next slide, please. We have had the benefit of utilizing pathogen sequencing, genomics, to understand host risk factors for a number of pandemic infections such as HIV. We know that there is the CCR5 delta allele that confers resistance to HIV-1 infection, and co-receptors have been targeted for the development of vaccines and therapeutics. Also, the Niemann-Pick type C1 protein, which is the cholesterol transporter, has been identified in vitro as being required for viral entry for Ebola viral disease. And it does confer in vitro resistance to the disease. What is interesting to note that these two genetic variants for diseases that are highly prevalent in Africa have little relevance because of the incidence of these genetic variants fairly rare on the continent of Africa. Next slide, please. So there is the concept of parachute or helicopter research, and this is because Africa has been home to exploitative research practices for decades. The term safari research or parachute research arose out of this culture of exploitation. Public health crises have exposed the continent's vulnerability, unfortunately, to such practices, most likely during the Ebola virus outbreak. And the COVID pandemic, of course, is no exception, because the genomic data of the pathogen, which was originally described by a scientist from Congo, did take credit from a German scientist before there was public uproar, and recognition was co-shared with the pioneer scientist out of Democratic Republic of Congo. So the question of data exploitation out of Africa continues to be a challenge. There has been some move more recently to try and mitigate this exploitative process, but I would say that there's still a long way to go. Several important publications on discovery of new pathogens, dynamics of transmission, typically award credit to investigators from the global north, when a lot of the work is done in the global south, and the field work and the desk work, technically speaking, is done by colleagues in the global south. Next slide, please. So the project that we have funded by data science is looking at ways in which we can combat antimicrobial resistance in Africa using data science. Next slide, please. Now, we are doing this work out of locations in Nigeria and also in Rwanda. The work is primarily been implemented by a non-governmental, not-for-profit organization in Nigeria called the International Foundation Against Infectious Diseases, which is an organization that was basically set up to support research and in-country capacity building to improve our understanding of the epidemiology of infections in general, and to generate data that can be used for the development of new vaccines, and also monitor the impact of existing medical interventions. Next slide, please. So we've got laboratories across different locations in the country that support surveillance for different infections, particularly serious bacterial infections, originally starting off in children, but then subsequently moving on to the general populace. Next slide. Now, we provide opportunities for young scientists to get trained at the bench while working on different research projects which are largely funded by external donors. So the CAMRA project, next slide please, is basically trying to characterize a large biobank of archived bacterial isolates using molecular techniques and using whole genome sequencing to identify genetic mechanisms of antimicrobial resistance in these pathogens. And then we'll also be doing a prospective surveillance that will generate new isolates to understand contemporary changes in antimicrobial resistance. Next slide, please. So we have Nigeria, which has the largest population on the continent of Africa, but unfortunately has one of the poorest indices for health, still has a very high prevalence of vaccine preventable infections, but unfortunately the vast majority of these infections are poorly recognized because we don't have a strong diagnostic platform. Next slide. So patient management still depends very much on clinical diagnosis without laboratory confirmation. And this clinical diagnosis typically managed by empiric broad spectrum antibiotics, which clearly is a strong driver for antimicrobial resistance. So the absence of routine laboratory diagnosis fuels the drive for the use of broad spectrum antibiotics, and unfortunately this promotes antimicrobial resistance in the general population. Next slide. So we've had the benefit of acquiring external funding to equip a number of labs with state-of-the-art microbiology diagnostic equipment, such as the automated continuous monitoring blood culture incubators. We've also had to provide backup power supply to ensure uninterrupted power supply for optimal functioning of this equipment. We have large -80 refrigerators to store the clinical isolates. We've had to provide training for the laboratory scientists in the use of this equipment. Next slide, please. Now, so I come to our first ethical dilemma, where we've got external funding support to generate data. And over the years, we've had funding support from different agencies doing specific surveillance studies focused on specific pathogens. Now, the situation or in a setting where we have a healthcare delivery system that is usually not associated with a good diagnostic service, patients typically have to pay out of pocket for these diagnostic services. The very small proportion of the populace that is covered by health insurance, the health insurance does not cover some of these diagnostic services. So invariably, the vast majority of the populace end up getting empiric diagnosis. The some proportion gets the diagnostic service but have to pay out of pocket. And then the donor agencies who provide targeted support for a pathogen-specific surveillance are interested in generating data that is related to either the serotypic distribution of the particular pathogen or understanding the epidemiology of the particular pathogen. So then comes the question, when such clinical specimens are provided for laboratory workup, we identify and isolate a bacterial pathogen, who exactly should take ownership of this clinical isolates? For individuals who are paying out of pocket for the service, should they actually be selling their biological materials to the external agencies, the government insurance scheme? The same question should be asked of them. Or do all these isolates automatically belong to the donor agencies since they are the ones funding these activities? And then the next question arises that when these clinical materials are converted into a product that is potentially commercializable, how would the benefits of these commercial products be of relevance to the donor population from Africa? How do we ensure equity, fairness, and just distribution of such products? Next slide, please. There are also important ethical considerations when we are looking at surveillance in general, whether it's at the individual level or at the public health level. There are certainly risks that are associated with sharing the data, and of course sharing the data when it's done in a way that it could be taken advantage of by other investigators or by commercial entities. And I think the risk associated with sharing of data is probably illustrated by the encounter we had during the peak of the COVID pandemic, when in November 2021, the South African Health Minister and a team of scientists announced the identification of a new variant of the SARS-CoV-2, the Omicron virus, the Omicron variant of SARS-CoV-2. And even though the South African scientists did this out of transparency and trying to inform the global community about the risk associated with this virus, the consequence was a shutdown, international shutdown for several Southern African countries. And unfortunately, this had an adverse effect, which, strictly speaking, should not have been the case. So such responses could serve as a deterrent for sharing of data that could contribute positively to global health. Indeed, the response could have been different. For instance, activating the use of vaccines, deploying the use of vaccines more widely, rather than the shutdown for several countries on the continent. Next slide, please. So if we look at some of the basic principles associated with translating data sharing principles into practice. Next slide, please. Clearly, there is the concept of open science, and one would say that yes, open science in practice should promote global collaboration, because there is transparency, there is access to other investigators being able to reuse, redistribute, and also reproduce the research. But clearly, this has connotations which can sometimes be detrimental. Next slide, please. So the key components of the principles of data sharing would focus on largely 5 thematic areas. One, the project wants to ensure that the data is shared for an appropriate purpose that delivers a public benefit. And for people, the user has the appropriate authority to access the data. And it's coming from a setting where the environment in which the data is shared minimizes the risk of unauthorized use or disclosure. We also want to ensure that there is appropriate and proportionate protections that are put in place for the use of the data and accessing the data. And the output from the data sharing arrangement should appropriately be safeguarded before further sharing or release of the data. Next slide, please. Unfortunately, the global burden of disease distribution globally, we know that Africa contributes about 11% of the world population. Next slide, please. And we contribute about a quarter of the world's disease burden. And next slide, the proportion of contribution towards research from Africa is only about 2%. Now, if we look at the distribution of researchers across different locations, so in the United States, we have over 2,500 per million population, and in Europe, it's almost 2,000 per million population, whereas in Africa, it's about 70 per million population. Clearly, this dearth of researchers on the continent that makes a significant contribution to the global burden of disease is one that opens the continent up for exploitation. Next slide, please. So one would ask the question whether open science actually increases scientific rigor and research efficiency, or does open science increase the risk of predatory science and research parasitism? Now, next slide, please. The concept of global health is one that means different things to different people, different settings, depending on where you are at, what's going on in your setting. So when a question is asked about your opinion on the shortage of food and the rest of the world, for instance, the question may arise at some locations: what is food? What is shortage? What is the rest of the world? What is opinion? So the context in which we prioritize needs in global health sometimes calls to question the lack of attention to some of the local challenges. And I'll probably give a practical example of the COVID pandemic that ravaged the global north a lot more than the global south. So we had a global pandemic that, relatively speaking, spared the continent of Africa compared to Europe, compared to North America. And a place like Nigeria, which is the most populated country on the continent of Africa, as at the end of the COVID pandemic, recorded more deaths from cholera than from COVID itself. And as much as one would want to probe and perhaps suggest that maybe deaths from the COVID pandemic were underreported, it's clear that the impact of the disease on the continent of Africa was sparingly less severe than its impact on Europe and North America. And of course, that would also explain why it was difficult to actually mobilize the populace to take the vaccine for COVID when a lot of the countries were battling with epidemics like cholera, for which there were no readily available vaccines at that point in time. Next slide, please. Now, a lot of taxpayers whose money contribute to research and surveillance activities in low and middle income countries during some of these pandemics may ask the question, why should their tax money be going to support activities in other countries? But this quote from Nobel laureate Joshua Lederberg sends a message across that the microbe that fell one child in a distant continent yesterday can reach yours today and seed a global pandemic. And indeed, I think we are witnessing an illustrative example of the current pandemic with the mpox outbreak that originated initially from the Democratic Republic of Congo several years ago, and about 2017, there was a medium-sized outbreak in southern Nigeria, which did not attract any global attention. But of course, that same strain that caused the outbreak in Nigeria seeded the global outbreak that we witnessed a couple of years ago, and now the Clade 1B, which originated from DRC, is causing a lot of mayhem globally. If only several years ago, the global community had paid attention to what seems to be a local outbreak in a seemingly small and perhaps irrelevant population on the continent of Africa, we would have been better on top of the current pandemic. So I would just want to conclude by highlighting the fact that open science and data sharing ideally should improve scientific rigor and research efficiency if appropriately implemented. We could have greater community engagement, transparency, and equity from the global north and south. And I think these are key to successful implementation of open science and data sharing. Clearly, there is a need to strengthen capacity for infectious disease genomics, surveillance, and in particular, bioinformatics on the continent of Africa. Right now, there is a lot of genomic data that is being generated from Africa, from human hosts, and also from pathogens, but a lot of the data analysis is basically still relying on our collaborators from the global north. As a result of which, it's very easy to relegate the contribution of the scientists from Africa to the background. We need to promote ownership through increased national funding. And I'm looking forward to the time when the African Union, African governments, the different countries on the continent will contribute more to research at their domestic settings and not relying completely on donor funding from the global north. We need to co-create solutions and ownership with the global north. So it's not just the global north identifying problems and presenting solutions to Africa. There has to be co-creation and there has to be co-ownership of products that are developed from the ideas, products that are developed either for diagnostics or for treatment. So the data sharing should create a symbiotic platform and not a parasitic one. I will end there, and thank you very much for your attention. Thank you.
Yeah, thank you so much, Professor Barrow. That was very, very insightful lecture. You actually did a lot of justice to the topic. I'll encourage you to put in any questions you have in the chat box or raise your hand, and then I'll call you. We have about 7 minutes for a Q&A. So while we're waiting for that, I'd like to point out that the point Prof made about data exploitation is very real. A lot of work done in the global south gets most of the recognition in the global north. And that can be very discouraging. And that could really be one of the reasons why people are not encouraged to do research, because at the point it looks as if research is being stolen. Then also, Prof made a very important point about the ethical dilemma of sharing data. So he gave the example of COVID, where borders were closed, and it's escalated the problem. But the good thing is, I think the world has sort of learned, because this time around for monkeypox, countries are being discouraged from closing their borders. As it only else ends up complicating the problem, really. I think, okay, still while waiting for questions, Prof did also, I think, encourage open science, but with a caveat, really, because it can be misused. So while he encouraged open science, it is to be used with care, especially to avoid research parasitism. Prof also spoke about how at present it may look as if the impact of some diseases is more in the north versus south and vice versa, but it's a global space, and things that go around come around. For example, Group B streptococcus doesn't seem to be a major problem in the global south. So not a lot of attention is being paid to it, while the opposite is actually what is happening in the global north. So thank you so much, Prof. Please, if you have want to ask Prof a question, you want to raise your hand, or put it in the chat box, that's still fine. Okay, we have one question, Prof. And it is from Daniela. Daniela says, how are controlled access data sets being used to try and remediate the stolen data problem? Prof, did you get that, or do you want me to say it again?
Please, can you repeat that? I'm not seeing the question. Please repeat.
Okay. How are controlled access data sets being used to try to remediate the problem of stolen data?
Right. Okay. So that's a great question, and I would say that several countries on the continent do not have a central repository or a central database with the level of security and restricted access that should be the case. We have pockets of individual researchers that manage their data, and they have collaborators from different parts of the global north. So I would say that the regulation is not as tight as it should be, probably non-existent across a lot of countries on the continent. Now, the institutional review boards or the ethics review committee across the different locations are also poorly resourced. So the level of training and resources that is actually required to regulate that is still very weak. There has been some progress with developing the Nagoya Agreement, for instance, which some countries have signed up to, but the implementation of that is still a bit of a challenge. But I think some progress has been made along those lines. At least awareness has been heightened. And hopefully within the next few years, things will tighten up so that there is better regulation. Thank you.
Thank you, Prof, for that extensive answer. And I think that brings us to the end of our Q&A session for this. We'll still, if you have questions, please do stay. At the panel discussion, you'll have opportunities to contribute more towards this very key topic. So thank you, everyone. So without further ado, let's give a round of applause to our second speaker. Our second speaker is Dr. Gerald Mbua, and he earned his PhD in genomics and bioinformatics and is quite passionate about the integration of genome sequencing technologies in health and disease, outbreak investigation, pathogen characterization, and AMR surveillance. His key responsibilities at present include coordinating the data infrastructure for multiple pathogen sequence analysis, training, workforce development, and providing tech support to member states towards building sustainable genomic surveillance, as well as bioinformatic capacities at national public health institutions in Africa. So he's primarily with the CDC, Africa CDC in Ethiopia. Let's welcome Dr. Gerald as he shares his slides.
Thank you very much for the kind introduction. Let me share my slides. Let me know if you can see my slides.
Yeah, they look good on this end. Yes, I have thumbs up from the participants.
Perfect. I won't go again through the introduction, but my presentation is on data collection analysis for infectious disease surveillance. And then there I'll specifically look at the scientific and society considerations. It's a brief introduction, like you have seen from Prof. Stephen. We have over 140 disease outbreaks in Africa every year. And there's a growing concern of antimicrobial resistance, which is also a big threat. And what I can say right now, we are already in the middle of one of the public health emergency of international concern, and that is mpox. And we all know that this is also taking on the continent at a faster rate. So we know that also infectious diseases also need some critical kind of surveillance mechanisms. And these components are not so much well developed in Africa, especially we also need very diverse and dynamic kind of approaches where we know the continent may not be in a position to be in a position to have all this expertise. And also thirdly, the effective data collection and analysis mechanisms are very much essential if you are to build the mechanisms and systems for early detection, monitoring, and control of infectious diseases. However, all these processes are fraught with both scientific and societal challenges that need to carefully be navigated to ensure successful outcomes. So I extract this from one of the papers that we recently published in F1000, where we tried to catalog the amount of pathogen sequence data that has been generated from the continent over the last close to 12 years. That is 2013 to 2024. And we clearly see the continent has generated and shared at least 4.4 terabytes of pathogen sequence data, ranging from parasites, bacteria, viruses, and so on. And this number continues to grow. Here we show you an extract from COVID-19 data that came in from Africa. And almost many of these countries were able to do the local sequencing on their own, except for 2 countries that appear in red. But you clearly see that the capacity to generate genome sequence data from pathogen data is now available on the continent. So we are able to do this locally, which wasn't the case before. Yeah, but of course it has scientific considerations. Like you have seen from Prof, we know that much of these endeavors are benefiting other people, not majorly people based in Africa. And the data collection challenges are so many, but I try to pick these 3. One of them is the heterogeneous data sources. In Africa, like we have like data coming in from hospitals, and then within the hospitals, you have data coming from the laboratories, and sometimes the hospitals and the laboratory data don't talk to each other. It's kind of disintegrated, and in some cases where it is aggregated in one place, again, it may not be accessible in real time, in that it may be generated like maybe a few days, and then by the time it is aggregated, maybe months have passed or weeks have passed. So that is also a challenge that makes use of this data in a way that can benefit interventions. A little bit very complicated. And we all know that real-time use and generation of data is very key if we are to impact outbreaks. So for example, if you remember the Ebola 2014, 2016 in West Africa, one of the reasons that was pointed out as to why it managed to be the worst outbreak of Ebola globally was because it wasn't able to the time taken to make confirmatory diagnosis of cases and contacts was in weeks. So by the time you try to track an individual who you picked a sample a week earlier, they have met or they have contacted hundreds and hundreds of people. So you break the ability to do tracking of contacts. So that is one of the reasons as to why the use of this data may not be very much optimal, because it is not collected in real time, it's collected in different sources, and it never gets to a point where it is aggregated in one place. We also have like data coming in from community health workers who may not be structured within the formal healthcare systems also. Like in many countries, we have even people who are called maybe village health teams or traditional healers who are in so much contact with patients, but they never have to contribute their data they collect within the national health systems. Then we have informal reporting mechanisms and systems in communities, lack of surveillance mechanisms in place in many countries. And for some countries, they have what we call the national health data repositories that normally get data at the end of maybe a year or two. So meaning, even if you went to access data in the national health data repositories, it may not be in real time. Probably it may have data that is dated weeks or months or years. So that also makes it not so much usable in that sense. Then the data quality and completeness, I've talked about that also in part, but we know data that is not collected in real time, that is collected in different formats. Some is collected in using laboratory books or hospital books, not so much in electronic format. And in case someone needed to transcribe this data, you may find it has so many entry errors, even if it is within an electronic system. Those electronic systems may only be available in maybe urban healthcare facilities. So all that makes much of the health data that is being collected on the continent very much unusable. Then technological limitations in effective surveillance that may be due to, we have like systems where you have healthcare workers who are interfacing with patients. They are not so much technologically advanced, even if you delivered maybe data collection systems in hospitals or in laboratories, they may not be able to be comfortable using computer-based laboratory information systems or computer-based hospital information systems. So that limits the ability to track and ensure real-time data entry. Inaccessible to internet, if these data capture tools are web-based, then in places where you don't have real-time internet connection, you are unable to relay the data that is being collected to the national repositories or regional repositories. And then the lack of modern laboratory equipment for cases where you don't have access to modern hospital equipment or laboratory equipment, you may be unable to get the definitive diagnosis in time. So even if these samples maybe need to be shipped to a more advanced setting, you may not easily get there in time because you have like delays along the way. But of course, other challenges including consistency in the power supply and also inaccurate delay in data reporting and also sample referrals. Yeah, so further on the technological considerations, we have challenges in data analysis, and we all know, even if like we have said, these laboratories have sequencing platforms, the complexity of pathogen genomics data has a different kind of addition that it requires advanced tools for analysis. Even if you need to make interpretations, visualization, this requires quite advanced knowledge that may not be so much available in these centers. Then for cases where we need to do disease modeling to understand the spread, still this kind of expertise is lacking in many of the countries. Much as they may be able to generate the data, they may not be able to use it in advanced formats to make very meaningful predictive models that can inform effective interventions. Also, the need for integration of genomic and epidemiologic data, that's a big challenge in the continent because we have like limitations. Different systems may be used to collect clinical data. Different systems have epidemiological data. Then also different systems may be capturing the laboratory data. So making all the three different data systems to speak to one kind of infrastructure is lacking in many of the countries because I know like some of these, we are just playing a catch-up game that even within the ministries of health, these are different departments that in some cases may not be able to communicate with each other. Then the ethical issues regarding data privacy is very much key. And here we talk about data privacy and confidentiality. And the example here we can cite is the case of Mpox, where like initially we all thought the people at risk were the individuals where we have men who have sex with men, and even if someone presented to the hospital, many of them would be so much discouraging because they know the mode of contraction of the disease has been so much associated with more of like having sex with the same sex. And then, of course, to some extent, this would delay reporting of cases, even if they may be there in society. But of course, the challenge is if these individuals reported themselves to the healthcare systems, how much data will be collected on them, and are they sure this data will not be used to come back to haunt them? So the confidentiality is also an issue, and how many of these results are communicated back makes the patients either comfortable in presenting themselves for care or not. And then the process of informed consent is also somehow complicated in many ways, because in some cases, if you have a 6-page document that you're going to use to collect to administer informed consent, how many individuals will be willing to give you that much data to collect before you administer their informed consent? But also we have other challenges like low literacy levels and various cultural norms across the continent. We have societies where if a female needed to give informed consent, they need to go with their husband so that they can give informed consent. And in case you are to obtain it without their husbands or their partners, then this is unethical in some settings. So all these come in to affect the ethical use of data in Africa. And then the equity and accesses, we saw Prof talking about this. The continent generates a lot of data from infectious diseases and pathogens. But of course, when the Western world gets access to this data, they will develop therapeutics in a turnaround time that is almost very short. But of course, when time comes to ask for access to these therapeutics, either the costs are very high, that many of the countries that have generated this data has led to the development of these therapeutic interventions. The countries are unable to pay for this. And then in case, even if they are to be made available, they will only be dispatched when they are about to expire to countries that need them. The classic example here we come to was during COVID-19. Many countries wanted to access COVID vaccines, but of course they couldn't until maybe at the point where these vaccines were about to expire, then they are pushed to the countries that need them, especially in Africa. But we are here also experiencing the same. During Mpox, we have so many, Africa has the highest number of these cases, but again, how many of these countries are able to access the vaccines? I can assure you it's a handful, but of course the deaths are increasing, the infections are increasing, but of course these vaccines are being developed by pharmaceutical companies away from the continent, and they need to make a return on the investments. Much as probably the first cases that were used to generate these therapeutic agents were picked from Africa, you are unable to access the interventions when you need them. So that is also a challenge that comes in to haunt people who collect the data, generate the data, but also give access to the biofarmers to use this data to generate therapeutics. The global health equity continues to extend. We thought this had ended during COVID-19, but like we are seeing also during mpox, it has not gone away. So also the people who are collecting this data, the participants themselves who are giving up the samples for research to be made, they also we need to stand to benefit from the advancements that come from the samples that they are, because the person who is suffering from the disease is a person who should be given a priority in case therapeutic interventions are in place. But right now we have Ebola, like once in a while we have these outbreaks, but how many are able to access the Ebola vaccine? However much they may be in a trial phase, very few are able to access them, but also for mpox, almost none at the moment in Africa. So there's this fund, the pandemic fund that was formed just after COVID-19, and it has managed to raise a lot of money to finance critical investments to strengthen pandemic prevention, preparedness, and response capacities in Africa or in all countries globally, but with a focus on low and middle income countries, where a majority of these are in Africa. So the first round of the funding allocation is, as you see here. This is from last year's allocation. 37 countries were awarded close to $338 million US. But you clearly see only 5 countries were coming in from Africa, where I know the majority of the infectious diseases are coming from, and these have potential to cause epidemics and probably pandemics. But you clearly see these countries have not yet become a priority for funding to improve their infrastructure to respond and prevent outbreaks. So this is a challenge, much as we know the continent is more like the one that is generating majority of the data that leads to the development of the interventions. When it comes to receiving back the support to ensure they develop their mechanisms, we are, I think, not doing so well. Yeah, but of course, we also have social and cultural factors that also affect the spread or the distribution of infectious diseases. But also these coming from the fact that many healthcare systems in Africa lack systems that engage local communities to ensure accurate and timely data collection. There are cultural beliefs and practices that also influence how diseases are perceived and reported. So some of these also are associated with the way these diseases continue to spread in the continent. We have practices in some communities where individuals, even if they have died of HIV, they can be remarried off to relatives of maybe the partners. And I mean, like, we don't have mechanisms in place that can overcome some of these cultural beliefs in a way. We have societies that also practice very unethical practices such as female genital mutilation, circumcision that may not be so much safe in some communities. So there's so much that can also affect the distribution of infectious diseases in Africa. But also there's a need to build trust in public authorities, building trust between communities and public health workers and communities to ensure effective disease surveillance. But of course, they also have to learn from historical issues such as the mistrust that comes in from government agencies and international organizations that pose risks. We know there was a classic example in Nigeria, I think it was in 1996, during the trial of a new antibiotic for meningitis that led to deaths in communities. And I mean, that led to mistrust between government institutions and international organizations for years beyond that. Now it can go on to affect other therapeutic applications such as vaccine utilizations in the community. And of course, we have a responsibility to ensure that that trust can be built even after such unfortunate outcomes. I think that is all I had for today. Thank you very much.
Wow, that was really, really thought-inspiring and very thought-provoking in many ways. Thank you so much, Dr. Gerald. You shared a lot of point that for many of us, I think we're hearing it for the first time, that for instance, there are about 150 outbreaks in Africa every year reported. That's like amazing, and it's a lot. And we appreciate, especially the fact that most of us are in research, how difficult it can be to get quality and complete data, and how much funders' resources go down the drain when we're unable to do that. So thank you so much for really bringing that to fore. And there's something that you said that is really intriguing, which is the amount of data that is out there in the informal sector that we're missing. So really, from what you've even explained, it looks like over half of the data in Africa is just out there in that sector and nobody is using it. So it really can't contribute much to what we're doing. Thank you so much. You called for an integration of genomic and epidemiologic data, and that's something really close to my heart. Because when you look at PubMed, you see there's a lot of there. But how well are we integrating the ground? You really hit the nail on the head there. Yeah, so thank you so much. You have some questions in the chat, so I'll go ahead and read one of them. The first one, very excellent question, is what is Africa doing to bridge the gap in the advancement in bioinformatics tools? And you are definitely an expert in this one.
Nice question. So, I mean, like from Africa, through Africa CDC.
Yeah, sorry, I forgot. That is from Adewale Adejimo.
Okay, all right. Thank you very much. So I think from Africa CDC, we are trying to run a number of trainings, but basically we are interested in training individuals located within public health institutions. So that has been taking place right from the onset of COVID-19. We have trained close to 700 plus in short and medium term trainings in bioinformatics and genomics. And we have distributed sequencing platforms to a number of countries in Africa, but mainly we are distributing these within public health institutions. So I think the next level of training will be mainly the intermediate training, where we will be giving or extending intermediate training in terms of fellowship programs at selected centers of excellences in Africa. So I think just keep an eye on Africa CDC website when these fellowships are open, then you'll be able to apply. But these will be running from minimum 3 months to 6 months and beyond in some cases. But for now, I think the trainings in short and medium term, we have trained over 700, and it is time to move to the next, which is intermediate. And those will be in terms of fellowships where individuals can be posted to some of these centers of excellences in Africa for extended periods. Yeah.
Nice. You said something, which is that you are actually distributing these genomic platforms in public spaces. Is that sustainable, and how are you approaching it?
Okay, that's a nice one. So sustainability is a concern, we know. But of course, at the start, when these are distributed, there's a period within which these public health institutions can have access to reagents from Africa CDC. But beyond that, we imagine we are more demonstrating utility in those facilities. And these facilities, we know they keep receiving funding from the national governments through the line ministries. So they should be able to say, okay, I think we have seen utility of these platforms. The next year, time we are making these budgets, we include reagents within the coming in from the local government. So I think we can ensure there is utility and continuity beyond our funding period. So it is more of a catalytic kind of phase, but we hope these countries can appreciate the utility of these platforms, and then moving forward, they can integrate them within their national budgets. But also we have some funding mechanisms that can support that from Global Fund within these countries, that can come in and meet, some of these costs.
Okay. So we're joining you in this optimism. Ms. Daniela has a very good question too. She says, are there any legal conditions that can be put in place when African data is used? For instance, if African data is used for research, then any positive research output generated must benefit the source population. That's Daniela Matute.
It's a good one, but tricky again, because I mean, like, we also have a responsibility to share this data in the public space so that anyone can have access to it and develop therapeutics. But when it comes to having access to therapeutics, then you may not have a mechanism that can force these companies or pharmaceutical developers to come back and distribute these drugs free of charge or vaccines free of charge. But of course, we have a more responsibility to share the data, but we may not have a more responsibility to bend their arms and say, please, can you return some of these for free in Africa? That is still a challenge. But I mean, there are mechanisms that can be deployed, but of course, they are not so much straightforward that you can go into another jurisdiction and force them to come back. But of course, you appeal to their moral compass every now and then and tell them, you know what, this data was generated by the continent, you have a responsibility to distribute part of that back to the continent. So we keep appealing to their moral compass. We hope one day they can get the conviction to say maybe it's the right time to get this back to where they are needed the most. Yeah.
Okay, that's excellent. Thank you so much, Dr. Gerald. It's been a fantastic session. Adewale, Olivia, and some other questions. We've not forgotten you. Please, we'll move that off to the panel discussion so that we'll keep to time. Thank you so much, Dr. Gerald. We look forward to seeing you again in the panel discussion. Thank you. So now it is my pleasure to welcome the only lady in the house, and that is Professor Morenike Oluwatoyin Folayan. Her session is ethical, political, legal, social, and economic considerations for data science in infectious disease control and management. So she's doing quite a lot in these 25 minutes. So she is a professor at the OAU and also a faculty member at the Center for Bioethics, and a distinguished professor of oral pathology. She is also the DVC at OAU. She's wearing so many hats. She's a leading expert in bioethics with a focus on research ethics. Pardon? Okay, so with a focus on research ethics, dental ethics, and healthcare policy. She has made significant contributions to the development of bioethics in Africa, serving as a member of WHO's expert advisory panel on bioethics and the Nigerian National Health Research Ethics Committee. So let us welcome Professor Morenike to this cafe.
Thank you very much. I'm laughing. And first of all, I was intrigued with the introduction of the gender, which is a major consideration for me, but also to warn ahead of time that I have internet access challenge. And if at any time I'm not communicating, please do call on. I want to start by truly, apologies, I'm not putting on my video. When I finish, I'll put it on. I'm not putting on my video now because of my bandwidth problem. So this is it briefly, and then I'll continue. I'll be back at the end.
Yeah, we will see you. Yeah.
To first of all, acknowledge the brilliant presentation by the two speakers. As I listened to them, I was intrigued and I wished, oh, I've listened to this and then aligned mine. But I will be speaking briefly. I hope I would speak shorter than 25 minutes, but I am coming from 2 points. First, as a community leader, and second, as an advocate. So you would see my point reflected through the many points that others had actually reflected earlier, but it's with the voice of a community activist and the point of somebody who's speaking from experience of the research regulatory cycle, including the fact that institution also has a place to play. also has a part to play. I was the executive director of the Central Office of Research in my university and not the DVC. So briefly, I would want to explore the ethics, political and legal social aspects in the use of data for controlling and managing infectious diseases in Africa. And as many of the two speakers have done before, we have experience with infectious disease management. If there's nothing that we could learn from, we would definitely learn from Ebola. And I spoke a lot around this. We would definitely learn from COVID. We are now learning from Mpox, and there's going to be another one coming very soon. Is it dengue fever? We don't know, but definitely something is coming soon. And most likely, the global epidemic would be zoonotic infection. But just like the last speaker said, we have much more than this in the space. We've dealt with HIV, we've dealt with TB, we've dealt with malaria, and we have a lot more. These ones are politically inclined because they're of international interest. Because Ebola was not of international interest, because Mpox was not of international interest, it was regressed to the background. Now it's coming to the forefront. And we have many others that might just become the trouble to the world. Once again, acknowledge I'm an advocate and an activist, and I might speak very strongly in ways that I use words that might be generalized rather than limiting. So I'll be looking at challenges and opportunities for data use in Africa. And I liked the last question that was looking around strengthening the legal framework for data use. I also acknowledge the last speaker that noted that there are challenges, but please note, for me personally, I think there are opportunities, and I'll be highlighting this in the next few minutes. First of all is issues around ethical consideration. When we talk about ethical consideration of our data, we want to talk about issue of data privacy and confidentiality. And I'll be sharing some examples I've had to deal with recently. It's around protecting personal health information in data collection when we're dealing with these infectious diseases. One of the things you find of interest, especially when these infectious diseases have global interest, there's sudden flooding into Africa for the collection and the use of this data. Ironically, many of our systems are not strong enough ethically to safeguard the road of the influx of data, interest in this data. Not only do we not have strong ethical gateways, the problem at hand makes it also very tempting to open the gateway and ignore the issue of privacy and confidentiality. For many of us, you might know the issue of the Pfizer story. But if you don't know the Pfizer story, I'm from Nigeria, which was at 1996 at the peak of meningitis. Meningitis was a problem in Nigeria, huge problem. Maybe in West Africa, but definitely Nigeria, an epicenter. And it was periodic. And then at the start, in the framework of support, research came in and they harvested data and took data away. There were a lot of issues later. If you read around this, you hear. But then in the midst of those crises, like we had in Ebola, like we possibly could have had in COVID-19, and we probably are having now with Mpox and DRC, what does it mean for data privacy and confidentiality? What does it mean for those data that you are exporting into the spaces of global partners? It is not protected in ways by national policies, by institutional policies that opens up the space for this data to be used unwholesomely or wholesomely in the future that can increase our risk of losing intellectual property rights, as noted as the last question. Why I thought it was excellent questions. What does this mean in collecting those data for healthcare purposes? At the end of the day, it also turns for research purposes. How do you, in the midst of crisis, of a wanting, yet be talking about ethical consideration, rightful ethical consideration, including informed consent for people and ensuring that they really understood? It's just like, I think for me, at times of crisis, when you start to think of data privacy, confidentiality, ethical consideration in data collection, is asking a pregnant woman at the height of labor paid, asking her if she consents to collect data when she's having children, or do you consent for me to observe your delivery? Which mother at the height of labor pain gives you consent valid consent. I think those are the kind of crises we have to deal with when we're thinking of ethics in the midst of pandemics. And there are help coming, seeming help coming, and yet we have to share data and yet collect even this data for somebody who's coming for healthcare, and we say sign consent, we're going to use this for future research. How valid is this? And then when we're talking about these issues of data and exportation of materials, as is already noted, where does equity and fairness come in? Disparity in access to health, even that results from the use of this data. I heard very well the last speaker talk about open access, but within this open access, where is fairness and justice? There's open access, but then we must also learn what is it that you openly access. I can tell you with my own experience, without bias to the North, I had partnership and I was enthusiastic about this partnership because I had 4 major big data of 22,000 participants. And I was willing to go into this partnership. And then just as a game, I asked, it's open access data, darlings. And then I asked, okay, what data are you bringing on board? And they said none. And they're going to share with me, red cap. And I just went, who are you joking with? Red cap. I'm talking about sharing data. I have 4 databases I'm bringing, big databases that can generate up to 54, 55 manuscripts from this, that can generate intellectual property, issues. And then you're bringing to me red cap as an exchange. Where are you coming from? So, this is but yet we have to make data accessible out there. And we're currently even dealing with one now that is looking at transgender data that they never had. We want to share it, but then what are they doing with this data? It's trash. And then I'm talking about what we're dealing with as of today. How do we do this? This is open data. We need to access this open data. But then this person, what is going to analyze, is going to tell a story that is not truly reflective. Do we give this in the name of open data? Yet we cannot keep it because there's open data. So issues about equity, fairness, representation, which also aligns with beneficence and non-maleficence in terms of balancing the benefits of data use and the potential risk of the data use, is something to consider. I apologize that I am raising a lot more questions than answers. But ironically, this is what ethical consideration is. You end up asking questions and questions. I don't have all those answers because as at of date, we as a continent of Africa have not harmonized our response to this, but I do have my own prescription as concerning how to go forward, because this is becoming problems that we're acknowledging, but it's not enough to acknowledge problems, but we must have solutions. Of course, political consideration. We do know that to navigate all these issues, there's a place for the governments of our nations to do. I really applaud the excellent stories and how far we've gone, especially with genomic research on the continent and transport of specimens. But our government still has a lot to play in terms of policies in place for data collection, data sharing, and use. It's true there are global standards. However, even our government in themselves has to put in place national policies, which itself kinds of supersede whatever the international says. Okay, so that places that there's a gap. And as I'm talking about political consideration, and I'll be moving into legal issues, you would recognize that as Africa, we are long overdue to become harmonized in our regulation the way we otherwise should be seeing it in EU. EU is very harmonized in its regulation. And because of the harmonization, there is a lot of streamlining going on. Unfortunately, in Africa, it's so fragmented. It's not only fragmented as a continent, it's fragmented even as subcontinents, where we should otherwise be strong. And I think even in all this, South Africa is at the top of it. West Africa is worse. But West Africa is a community of multi-languages, which itself is limiting the success of the political strength in regulating data use and material transfer. So we need to navigate this. We think there's a place for individuals pushing the government to respond. A few governments have responded well in terms of controlling data collection, sharing, and use. And I very strongly celebrate South Africa, who is doing very well on that. But as a continent, this is what we're talking about. When South Africa is strong, why can't the whole continent be strong by aligning with South Africa? But because we're fragmented, we're not seeing this. And we're not aligning. EU is there. I don't critique you, but I'm an advocate. And I'm asking you, AU, where is this voice? Even though we had cholera, we've had cholera with us forever. We have Lassa with us forever. We've had Ebola experience of 10 years. We have had COVID, now we have mpox, and we're still talking of a failure of a continent with policies and regulations that are not harmonized. We always sign into international corporations as Africa. We align with global health issues. When others are not aligning, we are always aligning. But even in this alignment, what does it mean? What does it mean for us as a nation in terms of intellectual properties? I feel right now with mpox, so we're talking about the need for vaccines. This same need for vaccine, we made noise for it in Ebola. We made noise for it in COVID. Now mpox has come to us and we're making the same noise. What is the noise we're asking them to give us? Whereas we're still waiting, putting our papers into place for us to be local producers of vaccines, in the response. Okay, that is out of line with data sharing and data use. But when we continue to be beggar for help, you would not be controllers of data use and data sharing. You are going to always have to give it up, and they use it for our good. We have to start politically strong if we are talking about strengthening the continental response. Of course, it has to be will and leadership. But I think there's a will, but there's no leadership. But this is a personal opinion, because there's so much will expressed in the many papers and the many documents that flies around. However, movement from these papers to action is slow. Sadly, it's because we're depending, of course, as beggars again to the international front, asking for support to translate our own need and our papers into action. Okay, so political leadership cannot be undermined. But then, is this where it's going to stop? I mean, is this the limiting factor? That's why I will be talking about institutional place. I think even within the context of political leadership, and we're looking at AU and African CDC, who is doing very well, I must celebrate that excellent leadership, even in pandemic response. However, please note that data sharing, data use, specimen exportation is beyond pandemics. And we've heard that from our previous speakers. It's beyond pandemics. So who is responsible for peacetime actions when we're talking about data use, data sharing, and intellectual property rights acquisition from this data sharing? For me, I feel very strongly that the institutions can play a role. It is true the global can, it is true politics can, but even institutions that allows for those data sharing, there must be institutional policies. And I think for me, I place institutional policies within this context of political consideration and helping maintain data sovereignty. One of my major concerns, and I always speak where we have so much people going for PhD. Do you know how much samples leave the shore of Africa in the name of PhD programs happening outside the country? Do you know how much data leaves the shore of Africa in the name of PhD programs happening outside the country? And there are no regulations, or they're limited. Don't let me say no. For me, for example, when I was the executive director, this was critical for me, and I had to push policies around this. Data management policies, they right from the nation. You can't export data and sample. So if my own institution controls, even if the political space in Africa and the nation is still finding their way, we can instead put measures for ensuring control. Of course, legal action stems from the national. And many countries have data protection laws. I don't know if it's happening. I don't know how many countries in Africa. Sorry, I think I had in a glitch, but I hope you're hearing me. So I'm talking about legal consideration and the issue of data protection laws. Many countries do have that data regulations, but what we have a challenge with is the compliance and enforcement. There are laws, at least for my own country, I know there are laws, but compliance is poor. What mechanisms are in place? You'll be even shocked that the research institutions that are supposed to be walking through this don't even know those laws, least of all enforcing them. So these are issues when we're talking about data use. Cross-border data sharing is a big deal. We must write it, especially now when we're looking at infectious disease. We can't overemphasize it. Cross-border issues are critical. But cross-border data sharing is critical, and legal frameworks protecting the transfer of data across borders. We must address that. I was listening to a peer very recently who was looking at He was doing his PhD, and then he was moving his sample in his travel bag across the airport, through airport. I almost collapsed. I just was beyond me. You are moving samples in your travel box? I mean, how does that happen? How could you have moved out across the border? Who did not check and pick that sample? These are the kind of things we're seeing, when legal frameworks are not properly in place. And of course, liability and accountability. I think everybody has a role to play in this, including we local researchers. Of course, social considerations when we're talking about data, cultural sensitivity, understanding and respecting cultural norms. I think for me, once again, I recall I say I am an advocate. One of the things you see about these issues about cultural norms and values in data collection is the way we use people to get into the community to collect this data. We use trusted person. Researchers use trusted person. And I'm consciously stressing the word use because we use. If you are a visitor into the communities, they will query you. But because you use trusted people, they are trusted and they're not queried. And then data goes without consideration for norms around the way we respect the names are used, the way things are represented. In a day of decolonization, and I'm doing a lot of work around decolonization, these are areas we should be looking at. What does it mean in terms of data sharing that is not subscribing always to the international norms, but a recognition of the cultural norms? One of the highest success I celebrate is the way we brought in cultural sensitivity to informed consent. Informed consent was, definitely, ethics came from the North to the South, the global South, in an attempt to ensure cultural sensitivity. We were able to successfully put and recognize the place for third parties in obtaining informed consent, where we recognize that for adults, if you are married, there's a place for assent from husbands in those cultures, but assent of those third parties does not supersede the consent of the individual. There also is the recognition of consenting of data collection, even from the community, asking those permission. This was the four works of people in Africa as bioethicists, putting onto the table a recognition of the social context. And there's quite a lot of issues in this respect that still needs to be formed. So there's still a lot of work for us to do. And of course, unlike other places for Africa, community involvement in decision-making around data is critical. Please don't continue to make us sign that these are data and specimens, whatever, how important they are used, are going to be used forever, including even this open science. Where's the voice of the communities in deciding about open science with data that is generated from them? Once they get data from the hospital, how it gets into international space, they have no say. They have absolutely no say. And I think these are things that we need to look. Once again, I apologize. I'm raising a lot more questions than answer, but these are things I think we need to start throwing on the table and opening up discussion. I have paper around this trust, building and maintaining trust. It is a norm that is not measurable and open to exploitation. And I keep asking, it's true we're building and maintaining trust, but I think we replace the word trust into accountability. There must be accountability mechanisms replacing this trust that enables us to go to courts and ask for adjudication around cases that we feel, a breach of cultural or social issues. But right now, it's about trust, it's about transfer. There is nothing contractual per se in a data transfer and material transfer as at now that enables me as an individual go to court over the use of my data at an international space, because I am blocked out in some way. And that simple informed consent seems to say that when my data crosses the border, I have no hold of it. Yet when I was signing that consent, that is not really what I was signing. So these are some of the things I think in social consideration of our data we need to look at. And of course, address public perceptions. I am not saying there isn't space for open data. I am just saying that within this context of open data, data sharing, data transfer, data crossing, data exploitation, that all these issues need to be considered in ways that we are all comfortable at the end of the day and subscribing to what is public use of data. There are challenges and there are opportunities. I've said that. a challenge continues to be our fragmented legal system in Africa. We need to address that. Limited resources for implementation. I think it's about not giving it priority. And of course, there's still resistance to data sharing and fear and concerns. We do have reasons for that. Okay, but we must acknowledge this and address it. Of course, one of the things I say locally, I apologize for my language, we own the disease. We must sell our disease. How can we have diseases, over 140 from the last speaker? When I talk about this, I say 100, and we are still poor. We must sell our disease. We had HIV, we have malaria, we have TB, we have mpox, we have cholera, we have Lassa fever, and then we are still poor. They always come and harvest all this data, and they become rich on it. They develop items. How come? We have to be wiser at this business. Okay, so we have to leverage the data as we have. These are opportunities for 1,000,001 things. In my own country, you cannot come in and collect data without the local investigator. But then what happens with the local investigator? He's just happy and celebrating that it's part of the process rather than looking at the IP can. We must improve our health outcomes through targeted information from the data we generate, and all and above, our regional collaboration must be addressed. I think finally, I'll put this recommendation. No, I can see facilitator, I have to add. Ebola taught us a lot of things. There was data exploitation. Until today, we never recovered it. COVID-19 has taught us about data management. We have successes, but we still have challenges. Malaria control is a lot.
We can't hear you anymore. I think maybe the network. And did we lose Professor Morenica? Prof, are you there? Yes, okay, great.
Yes, I'm there. Sorry, I lost me for a minute. I think I better just, what he's telling me is I should just round up. All right, so in terms of ending, I think you've heard it, and I'm just summarizing. We need to strengthen our legal and ethical system. Capacity building for ethical data management should be in place. It's not a one-off training, the continuous training. We cannot do this without community involvement. And yes, our international collaboration is very important, but we are asking for sensitivity for the African context and local context when we are talking about this collaboration. On that note, I'd like to say thank you for listening and being patient with me and my internet and over. Thank you.
Thank you so much, Prof. That was very, very fiery, very passionate, and you got all of us on the train of the social, political, ethical, and legal considerations of data sharing. Thank you so much. You shared so much. And we can hear it from your voice. It's actually from your experience on the field. The funny thing you said about let's sell our disease, I think we should take you seriously and do sell our disease. A lot of things you said, I think it resonates with a lot of us. I know many hospitals right now where women are in labor and research assistants actually on top of their head. Please, ma, do you want to give consent for really? It doesn't make sense. So I really hope that maybe all these presentations are not really 25-minute presentations, because there's so much to unpack, so much to discuss, and so much to negotiate and strategize around this. Thank you so much to our three excellent speakers. Do we have questions for Professor Morenike? We will only possibly be able to take one or two because we're 9 minutes out of time. Yes, Deborah has her hand up. Please, you may go ahead and speak. You have the mic, Deborah.
Thank you so much for such a beautiful talk, and to Dr. Amboa as well. You talk about issues that are very pertinent in regard to informed consent, the informed consent being very detailed, and participants not being able to understand what is entailed. I totally agree with you when you talk about issues around intellectual property, and sometimes there are concerns around whether African researchers even understand what intellectual property means, and not forgetting the absence of a benefit sharing framework. I would like to hear from you what your recommendations would be around protecting the rights of research participants whose data has been shared, and also ensuring equity through this collaborative research. Thank you.
Deborah, I think you asked an excellent question that is going to need extensive discussion and deliberation. I think for me, remember, once again, I'm an advocate, so I have many arts. I think actually it's very dissuasive when individuals give their own, whatever it is, data specimen, and we generate intellectual property rights, and we make money as researchers, and then there is the participants actually have nothing, you know. And then, or one of the things I say, just as synonymous to this, is that we ask volunteers to give everything free, but we, the researchers that are using this free, earn millions of dollars being researchers, you know. So where's the equity and fairness in this voluntariness and data collection? I don't have an answer, but we must troubleshoot. Excellent question that needs to be troubleshoot at every opportunity that gets us to start deliberating and think using the fairness and justice framework to acknowledge that volunteers that gives us has a right to earn from even all those processes. How that works, I don't know, but and I don't have an answer, but I think it's something excellent I want to go forward with. Thanks for raising it. Over.
Thank you, Prof. I think you actually answered the question very well. Thank you. There's a question for Dr. Gerald about how students can access the services at Africa CDC. Do you want to guide us, please?
Yeah, so I think from the website, we all post many opportunities that are running at any one time. So I think the best way to advise any student is to keep checking on the website, but also beyond that, the centers of excellences that work with Africa CDC, like SERI in South Africa in Stellenbosch, the SCGID, which is also a partner on the grant itself here, they all keep running these opportunities that we keep posting in case we don't have any that is fully funded by Africa CDC. So I think my quick advice is keep checking on the websites of these centers of excellences, but also the ones for Africa CDC. Yeah.
Great. Yeah, thank you, Dr. Gerald. I think this last question is probably for Dr. Obaro. It says, how can Africans have full control over data generated in our setting, irrespective of the source of funding for the project?
So thank you very much. I think it boils down to different national governments providing a platform that will enable them to take ownership of the data by contributing and supporting a strong health system. Currently, I think that varies is on the continent. Some countries are able to lay back ownership because they have a robust platform, but that's not the case across most other countries. So I think that would be the place to start. I hope that answers your question.
Yeah, yes, in many ways. And I think for most of these discussions, it's something we should plan. They continue evolving. And so it's something that will be a continuing conversation. Now, because we're out of time, we'll give 30 seconds, if you don't mind, to our speakers. Just 30 seconds to say some burning last words before we wrap up. Please, let's start with Professor Obaro in the order we presented.
Okay, well, thanks very much. I don't think I have much more to add. I think the summary from all the presentations just points to the fact that national governments across countries on the continent need to take more responsibility for providing a strong healthcare platform, a strong research platform, and funding for indigents to take responsibility for their welfare and not be completely dependent on external funding agencies. Thank you.
Thank you, Prof. Dr. Gerald, 30 seconds of burning thoughts.
Okay, so I will take off from where Prof has ended. I think at the country level, but at an individual level, I think each one has a responsibility to learn as much as they can learn and try to use the data they have access to improve health on the continent. That's my submission. Thank you.
Yeah. Thank you. And Professor Morenike, who said the politics has made us professional beggars. Really? That's the way it is, I guess. Please, your 30 burning thoughts, seconds of burning thoughts.
Yeah. I think for me, the last thought is that, look, we all can make a change. We all can make a change. Let's use what we've learned today to even change a little thing and ask your institution for what their legal policies are. Whichever institution you're working, just ask and demand and push and support and make it happen. If that is all we've done with this lecture, I celebrate it. Thank you very much. Over.
Oh, yeah, thank you very much to the best speakers ever. We're really grateful and privileged to have you on this platform, and also to thank a group of people who are actually behind the scenes but have contributed so much to the success of this. Please, if you can show us your video. Dolo, thank you so much. Nchangui, thank you so much. Daniela, I can't see you, but you've also contributed so much. It's been a large team working behind the scenes to ensure this happens across CAMRA and PUBGEM. So thank you so much. Dol, we're hoping to see you and Changui. Can we see your video so we can thank you? Yeah, thank you. Thank you. So thank you, everyone, and we look forward to having you at our second webinar. If you would like to get in touch with any questions following this, feel free to hit us up on our Twitter handle on CAMRA or PUBGEM-Africa. We'll be happy to respond to you. So bye, everyone.
Bye-bye.
Bye.